So we're super excited to have Dr. James Fink with us. For those of you who don't know, he has been actively engaged in researching Dup15q for how long now?
2015.
Since 2015. He's the example of someone we called a hold of during his postdoc time, and we said, hey, you're interested in it, come on, and we have not let him go. So I know, right? I mean, seriously, he doesn't have a child with Dup15q. He is so committed. He serves on our science committee now, and he's just continuing his work. And let me tell you, he is quite the advocate. So I'm excited for him to tell you a little bit more about ASOs, and take it away.
All right, thank you. Thank you, Carrie. So I've had a few conversations actually over the last few days at breakfast and lunch about ASOs, and I think that one of the reasons that it's important to talk about why, what they are and why they matter is because I think you'll start seeing a lot more of them mentioned in the media and the websites and being used for similar syndromes. So I think it's good to start educating now and understanding what it is, because you're going to start to see this more and more. So let me click forward. All right, so I'm trying to balance here, engaging with you and looking at the slides from the screen. So I'll give like a basic science lesson, I think, to really understand this. So please feel free to ask questions or find me afterwards if anything is not sort of clear. Also, because I'm breaking this down simply, there are a lot of complex things that are just not captured by this. So just keep that in mind as we go through the talk. But there are some basic genetics 101 that you need to understand to really grasp what an ASO is. And I have those 2 bullet points on there for a few different slides, so you'll continue to see them and read them if you want to as I talk. So there is DNA that they're in your cells and it encodes your genes, and DNA gets made into something called RNA, and that's a message that the cell uses to create a protein. And the protein are the little machines that exist in cells, and cells use proteins to do things. And the therapies and drugs that you've been hearing about and are being used to treat all types of diseases target different parts of this pathway. The other word to use for DNA is your genes. And RNA can be called something that's known as a transcript. And protein is just a protein. There's no other name for that. And why is this, why do we think of genes here in Dup15q? And that's because of this complicated diagram that many of you are familiar with, because the Dup15q patients in this room and out in our world have these genes that are changed in their genome. And there's not just one gene, there's many genes, and it's not the same many genes for every patient. It's different from patient to patient. But there are many shared genes, and that's an important point. So this, I think, is a starting point of, in this diagram, where do ASOs come into play, and this is sort of considering genes. So an ASO is a little piece of RNA-like material. So it looks like the RNA on the left-hand side of the screen. And what's interesting is the way that DNA and RNA work is that they're complementary to each other. So you can sort of really pair them in specific ways. And I have better illustrations of this on the next slide. So they can also be specific, right? I just showed you a cartoon where it's just a little piece of RNA and a little piece of ASO, but in this instance, I'm going to talk about UB3A. So UB3A is a gene, and that gene has sets of letters, and each letter is represented here by a little piece of the ladder on this RNA. So there's a UB3A RNA, and then you can design an ASO that's a UBE3A ASO. It is not a HERC2 ASO. It is not a GABA ASO. It is specific to UBE3A. But you can make GABA ASOs, and you can make HERC2 ASOs if you wanted. And how this works is because in your cells, every transcript, every RNA has a set of letters that is specific in a certain order to that particular transcript. And because we know that, we can actually design a complementary set of letters that is specific to UB3A. And so that's also true for every other gene. So not only do we check that it's specific to UB3A, you can also decide whether or not it matches other genes that you do not want to change. So that's another important consideration. So this is the only complicated slide in the entire presentation. But I think it highlights that this is much more complicated than just sort of DNA, RNA, and ASOs. But the highlight that I want to take away here is not actually that it's complicated, it's that there's lots of different paths you can actually use ASOs to tackle. So just because genes are overexpressed in Dup15q and you want to reduce them, doesn't mean they can only be used for reducing genes. You can use them to increase genes. You can use them to increase genes in several different ways. And cells are very creative, and ASOs are able to hijack some of the creativity of cells to change and modify genes in ways that are beneficial depending on the syndrome of interest. So bringing it back to why it's important to know about ASOs, and I think this is really the good part about the talk that I want to make sure you take home, which are that ASOs are approved for CNS indications. CNS is central nervous system, so disorders of the brain. So this is an area, Dup15q falls into that very large bucket. But this is something that's already being used. It's, again, been approved for other neurological disease. There are also, in the next level, ASOs who are currently in clinical trials, and those are in clinical trials for related neurodevelopmental disorders such as Angelman syndrome. And this is another reason I think it's important for you to know about ASOs, because a lot of people, your clinicians and patients here and scientists here, know about Angelman syndrome because there's a lot of similar genetics. And so when you see in the news or you look on the websites and you're Googling these things and you see there's ASO for Angelman, you should know about this and how it might apply to Dup15q as well. But Angelman is not the only one. There are many more ASOs than this in earlier development for other related neurodevelopmental disorders. And we talk all the time about how many of the patients look similar to patients out there with other genetic syndromes, and that's because that they affect similar things in the brain. They have seizures, they have motor and muscle tone issues they're handling, and so many of these similar neurodevelopmental syndromes have ASOs in development. And again, some of them are reducing these genes, some of them are increasing, but these similarly have patient advocacy groups. They're educating their community on these types of things, and so I think it's important for you to be aware that for any of these other epilepsy and neurodevelopmental disorders, that these things are happening in the background, including, and excitingly, I think this is on the website in terms of the pipeline, the Dup15q UBE3A ASO from Quiver Bioscience and also Kicho. And I imagine there's actually many others that are not publicly disclosed, because this is, people are working on things all the time. So I'd like to end on sort of 3 points: the benefits, the challenges, and the excitement. This is not meant to be exhaustive, but I just tried to think of the 3 or 4 key things. So the benefits, again, is they can be made to be specific. They can be made to be not specific as well, but you can actually design them to be very specific, and certainly when we do this, we screen to ensure that they are as specific as possible. They have the potential for being disease modifying. So a lot of our medications are meant to treat a symptom. Now, this is still to be determined, but the idea is that if you're changing a gene, which is sort of a really important part of the pathophysiology of the syndrome and of Dup15q syndrome, then that might have much wider effects than just treating a particular symptom. This is what we'll find out in clinical trials. There's been so many awesome talks and panels and discussions around this in the previous days, but there's the potential for this to be the case. And the other really interesting benefit, I think, is that brain cells take up ASO. That means the ASO gets into cells easier than it does for some of the other promising approaches that tackle this type of gene modulation. With the benefits come several challenges. Again, this is not exhaustive, but one of the major ones that I think of, and I think lots of people think of, is the delivery. And that is for central nervous system, because you need to get to the brain, you have to find a way to get these things there. And right now, the technology is not at the point to be able to do this more specifically. You have to deliver the ASO via an intrathecal injection. I mean, sort of like a lumbar puncture into the spinal cord. It then accesses the space and the fluid that bathes the brain. And it's made harder by the fact that we want to get to the brain. So now not only are you doing an intrathecal injection, you have to give enough at that location to get it to the brain. And that has some other things that we need to sort of think about. And then I think the second point, although ASOs have been around for a long time, in this way, it's early days. So there's a lot of ASO types, And people are learning more and more about ASO chemistries, and changing chemistries do lots of different things. It keeps them around longer, it helps them get into cells better, it can reduce some of their toxicity if that's a concern for a certain ASO type. And I think that's something we're going to keep learning about. And the excitement is also that it's early days. I think that the ASO technology, the delivery technologies, not even the ASOs, are only getting better. So one of the things I constantly think about is because it's a piece of genetic material, that's the medicine. That doesn't necessarily need to change. So it could be that an ASO today for Angelman syndrome, which is a set of letters, that same set of letters might be even more effective in several years when the delivery through a device or by some other means is even better. So that makes me excited. I think it's a really exciting time to be thinking about these RNA-like and genetic medicines. And with that, I'll take some questions.
Right, if somebody will run the mic in the back, we'll do this again.
Hi there. I'm understanding the idea that it's a therapeutic, it's sort of a medicine, and that it's has to do with DNA. But I'm having a tough time contextualizing, like, what is it? Is it a protein? Like, how do you make it? Like, in a simple way, like, just what is it?
Yeah, so you synthesize it. It's a piece of RNA, pretty much. I mean, there are little, so in the case of one where you're reducing UB3A, it's actually a DNA RNA-like hybrid. Some of the things you're using aren't exactly like RNA, so we don't say RNA, but they are synthesized in the same way that RNA would be in a cell, but it's done in a lab instead. So it's actually a set of letters. So we have, the drug would be, let's say 25 letters in a row, and the letters have to be this exact order, and that would match a very specific part of UB3A. And it's that part of UB3A because we find after lots and lots and lots of screening that exact set of letters does not hit any of the other genes that we can see, and it's not in cells and in animals, it's not causing problems, but it would be a vial in a resuspension of RNA. Yeah.
All right, Jackie's running one in the back. Go ahead, Jackie, we'll take one from the back.
You mentioned at the end of your talk new developments in delivery mechanisms. Can you talk a little bit about what we have to look forward to delivery-wise?
Yeah, so one of the things we think about all the time is if implantable devices. So ASOs, because of the delivery through the spinal cord, you have to give a really high dose. And we're learning more and more about this, and certainly all the clinical trials that are happening will teach us more. But there are concerns about local effects in the spinal cord. That's not the area we necessarily want to, for this case, want to be hitting. And so it'd be much better to have something near the tissue of interest, the brain in this case, and you could actually, since you're close to the brain, almost like a spritzer, deliver small amounts of ASO. The other thing is ASOs do wear off over time. So the other inconvenience, I should have actually put this as a challenge, is that it needs to be intrathecal delivery every few months to maintain levels, right? That's also really a challenge, as people know here, when we were talking about clinical trials and recruitment and such. And it's certainly not convenient in any way, but if you had something in the brain, not only could it deliver the ASO over time, and you wouldn't need to sort of re-administer it through intrathecal delivery, but it could also potentially censor the amount of ASO and release based on how much it's sensing. The final thing that's really interesting, I know there's companies working on this, is there are other indications where you want to avoid the spinal cord exposure at all costs. So you could have feedback devices that can control the flow of the cerebrospinal fluid to keep it in the brain and prevent it from getting to the spinal cord. These things are also in early phase clinical trials, so they're in the same place as the ASOs are, so we'll have to see how that goes. But I think that there's lots to look forward to in that way.
You mentioned a trial currently going for Angelman syndrome. So is that, when they're delivering that, is that through the lumbar puncture?
I believe so, yes.
Oh, okay. Hi. So my question is simple and kind of related to our first one. In the sense that when you're showing your diagram where your RNA comes and it transcribes for protein, right? I think some concern that a lot of parents have is that our kids may be transcribing different proteins because our genes are different. So what is happening when the ASO merges with that RNA? Is it preventing a protein from being formed that could be causing symptoms, or is it just changing the protein? So is it stopping it, or is it changing it, or is it not doing anything with the protein? It's just silencing.
Yeah, that's a great question, and I think the different flavor of ASOs can be different pieces of that, but the way these would work, it would be at the RNA level, so it would prevent protein from being made. Now, this will get into one important consideration that we get asked all the time, which is that for UB3A specifically, loss of UB3A leads to Angelman syndrome, and that we know that's a single gene syndrome. And so you don't want to stop protein production of UB3A or any of these genes. I mean, it's there. Those genes are there for a reason. It's a certain level of those genes you're required. So it's not that it would stop protein altogether. You'd want to find the right dose, and that's dependent on which of the magical set of letters you have and sort of the profile of those letters, how much you need to get to that level. And that's potentially why, and again, with better technologies in the future for delivery, that you could get even better at controlling that, because you could constantly sense and determine how much you want to give to maintain the right level of protein. So just to repeat, the question was, is it blocking protein, silencing protein? It's acting at the RNA so that protein cannot be made, but it's balancing how much protein is made, so it's not halting it altogether.
I'm sorry, I can understand exactly what ASO improves in the individual.
Can you repeat that one more time?
What's
Yeah.
the end point for the ASO?
Exactly.
Oh, I see. Yeah, so it depends on what you're trying to achieve. I mean, I can't speak to all the other ASOs people are working on, but a lot of these syndromes have epilepsy. It's certainly a thing we're considering. It doesn't mean, again, the hope is it would be disease modifying, so it wouldn't necessarily be only to help epilepsy, but you do have to make decisions about what you can measure and really show with as much confidence as possible that this is having an important benefit to patients. And we have not committed to any of what the endpoint might be, but there's discussions all the time about what that could be, and it came up in the clinical trial panel yesterday that the Alliance is really a great resource in this way as a hub to put us in touch with experts like Shefali and Ron in terms of making informed decisions about not only what do they think about the endpoints, but what are other groups thinking about? How are they using endpoints again, because they're similar neurodevelopmental disorders.
Again, for additional clarity, and I have two questions. Is the ASO basically, to expand on the UB3A conversation yesterday,
Yeah.
is it normalizing the activity of the UB3A? In other words, telling it, don't degrade these things you shouldn't degrade, don't tag and target things you shouldn't target, is that what it's essentially doing?
Yeah, yes.
Okay.
Yes.
And-
So again, because there's still some UB3A around, because you need to maintain certain levels, that UB3A should be doing its job. It's just you're reducing the amount of UB3A that's around to do all of that.
So it's not making it more efficient technically, it's just decreasing the amount of
That's
it that's
exactly
acting.
right. That's right. So
Great.
each UB3A
Okay.
should have the same level of activity. There'll just be many less molecules of
Fewer
UB3A.
of them. Okay, and how soon might we have some results from this study for Dup15q?
Yeah, so we're going as fast as we can. There are results. I don't know, you might be able to even find it on YouTube. Just early results, right? These are not clinical trial, but there are, I think I presented at the science meeting a couple days ago, and I presented at meetings in the past, and we've had posters that we've shared on LinkedIn, and I'm happy to pass this to Carrie to reshare maybe through the Alliance. But we've shown about how we modulate UB3A in cells, how we're not modulating other genes, the number of molecules we've screened, showing that it works not just in neurons, but other relevant cell types. So there's a lot of interesting data to look at, and we're continuing to push and make this a priority.
Does anybody get really excited thinking, like, did you have any idea this much stuff goes on behind the scenes? I mean, isn't it fascinating? Let me check the time real quick because I
Carrie,
don't
while
wanna
you're
run over.
while you're
Yes.
checking, so
Go
James,
for
just
it.
real quick, just to confirm. So the current clinical trial that we have is from Roche. The work that Dr. Fink is working on is preclinical. So it is not in clinical trials yet. Not saying that you were asking that, but just we're not yet there, but this is that amazing pipeline that we shared. So it is hopefully coming to clinical trials. But again, as Carrie's saying, super exciting that we have all of this
Yeah,
happening.
fantastic. I think if you guys will, I think just a huge round of applause for Dr. Fink because
Thank you.